Tonight, a quiet story about surgery learning to fear the invisible. It's the 19th century. The wards smell of spirits, sweat, and something darker. Surgeons work fast because speed is kindness when there is no good anesthetic and infection is accepted as the price of operating. Patients live through amputation and then die of the ward. Joseph Lister is not the first to notice that wounds, clean at the start, turn foul. But he is one of the first to look at that fact as a solvable problem rather than a character of fate. He watches and keeps notes. He sees that compound fractures behave differently when the skin is broken and dirt is invited in. He sees that some wards rot patients faster than others. He is inclined toward gentle hands and careful observation rather than bravado. And then he meets an idea. Louis Pasteur's work on fermentation proposes that microbes, not air itself, drive rot. Lister reads the papers, thinks about the ward, and the pieces click. If living agents are the cause, then killing or excluding them should change outcomes. Air is not poison. Life in the air is the problem. This is a radical thought in a room full of miasma. In Glasgow, Lister looks for something he can apply at the bedside. He wants an agent strong enough to kill what he cannot see, but tolerable on tissue. Carbolic acid, phenol, already used to deodorize sewage, seems a candidate. He decides to try it not as perfume, but as strategy. He starts with a boy who has a compound fracture. Lister cleans the wound as best he can, trims devitalized tissue, then applies carbolic-soaked lint and a protective dressing, renewing it with care. He records, waits, and watches. The wound does not turn foul. The boy keeps his leg. This is not a controlled trial. It is not blinded, but it is a signal that refuses to go away. Lister refines his method. He treats instruments and dressings with carbolic. He prepares the skin, and he introduces a curtain of carbolic spray into the air of the theater, an idea we do not keep, but at the time it fits the model he has. Kill floating life before it lands. He writes about the change in his post-operative wards. Fewer abscesses, cleaner wounds, more patients discharged alive. He is careful to describe technique, not just results. Adoption is not immediate. Surgical culture is prideful. Nobody likes to be told that their hands carry harm. Carbolic stings skin and irritates lungs when sprayed, and the gear is awkward. Some surgeons try, then abandon it. Others reject it on aesthetics alone. But the results accumulate. Centers that apply the method with discipline see outcomes bend. Students trained in the new way take it elsewhere. The antiseptic idea moves from eccentric to necessary. It also evolves. If killing organisms present on the field is good, then keeping them out entirely is better. Over time, surgery shifts from antisepsis, killing contamination, to asepsis, not allowing contamination in at all. We replace the carbolic spray with sterilization of instruments, gloves, caps, and masks, designed airflows, drapes, and sterile fields. The best evidence for the concept becomes the fact that routine operations stop being lotteries and start being reliable service. Lister's contribution is not just a chemical, it is a way to think. He treats infection as a process we can interrupt with a system of behaviors. He writes methods carefully enough that others can reproduce them. He insists that observation should bend tradition, not the other way round. He accepts that parts of the method will be discarded as the model improves. This humility is more important than any reagent bottle. The story does have costs. Carbolic is caustic. The spray irritates staff and patients and does not add much once sterile technique matures. Early adopters sometimes over-applied phenol and harmed tissue they wanted to protect. Even now, when we talk about surgical site infection, we know it is rarely one mistake, usually a stack of small ones. The skin prep done well or poorly, the airflow, the glove integrity, the antibiotics timed or mistimed, the closure judged correctly or not. Lister's legacy is that we see those small things as levers. Why did it take so long to convince people? Because the change was conceptual. You cannot see a bacterium with the naked eye. You see its consequences days later when it is too late. You are asking a team to change dozens of small behaviors based on a theory they cannot touch, and to accept that the old ways had been hurting people. That kind of change is heavy. The way through was data, repeated, in different hands. When you listen for the echo today, you hear it everywhere. In the checklist voice that asks for the antibiotic given within the right window. In the pause before a line is inserted and everyone agrees which site is clean. In the quiet insistence that theater doors remain closed because the airflow matters. In the ritual of scrubbing, gowning, gloving, boring on purpose, because boredom is a tool when the stakes are infection. There is also a social echo. Lister, a surgeon, took inferential science from a chemist and applied it to the ward. The border between disciplines was a useful fiction. He ignored it. The profession is still at its best when it steals shamelessly from good ideas nearby and translates them into action patients can feel. If you want one sentence to carry out of this story, make it this: outcomes change when culture changes. Antisepsis worked not just because of carbolic acid, but because people agreed to be different, even when it cost time, comfort, and pride. That is the hard part and the only part that lasts. There is one more note worth holding, quiet but sharp. When antisepsis started to work, it revealed the value of operations that had previously seemed heroic and hopeless. You do not just reduce deaths, you expand what is possible to offer. The same arc repeats in antibiotics, in anesthesia, and in the protocols we update every year. Methods that look like bureaucracy are often the bones of survival. So, where do we land tonight? Lister saw, read, connected, tried, measured, and taught. He was wrong about parts of the mechanism and right about the direction. His wards grew quiet, not by accident but by intention. We inherit that intention every time we wash our hands as if it matters, because it does. This is MedTime Stories. True medical stories, told softly for sleep. Educational only. Follow local policies and guidelines. Thanks for your work today. Let the rain do the talking from here.